Welcome. Today, we'll explore a compelling case of persistent epigastric fullness, a common complaint that often presents a diagnostic challenge. We'll follow a patient's journey through evaluation and treatment. Our patient, a 38-year-old woman, presented with the primary symptom of feeling full after only a few bites of food. This sensation was persistent. The patient described a constant feeling of heaviness in her upper abdomen, accompanied by bloating and a mild burning sensation after meals. This had been ongoing for 3 months. It's crucial to note the absence of any alarming symptoms. She denied vomiting, gastrointestinal bleeding, or any unexplained weight loss. These are critical red flags. Her main concern was the persistent feeling that food simply sat there in her stomach, causing constant discomfort and a significant impact on her quality of life. As medical professionals, we know that seemingly benign symptoms can sometimes be masking more serious underlying conditions. A thorough approach is essential. Our initial diagnostic approach always begins with identifying potential danger signs, often referred to as alarm features in dyspepsia. These features guide our next steps. Alarm features include significant weight loss, anemia, persistent vomiting, dysphagia, gastrointestinal bleeding, or a family history of GI cancer. These require immediate attention. In our patient's case, a thorough review confirmed the absence of all these alarm features. This was a reassuring initial finding, guiding us toward less urgent investigations. Given her age, under 60, an immediate endoscopy wasn't indicated as a first-line diagnostic step. We proceeded with a more targeted approach. The next logical step was non-invasive testing for Helicobacter pylori infection, a common cause of dyspepsia. This is a frequent culprit. Her stool antigen test for H. pylori returned negative, effectively ruling out this bacterial cause. This was an important piece of the puzzle. Following this, we initiated empiric acid suppression therapy, prescribing a 4 to 8 week trial of a proton pump inhibitor, or PPI. This is a common approach. While the burning sensation she experienced faded slightly during this trial, the persistent post-meal heaviness unfortunately continued to linger. The PPI wasn't a complete solution. The lack of complete resolution prompted us to broaden our investigation, searching for other potential organic causes of her symptoms. We needed to look deeper. Could this be gastroparesis, a condition affecting stomach emptying? We considered her medical history and other factors that might contribute. She had no history of diabetes, wasn't on narcotics, and her thyroid function tests were normal, making gastroparesis less likely. We ruled out some key causes. To definitively rule it out, we performed a gastric emptying study, which subsequently returned as normal. This provided further clarity. Next, we considered biliary disease. An ultrasound of her abdomen revealed a clear gallbladder, no stones, and normal bile ducts. This was another negative finding. Pancreatitis was another possibility, but her lipase levels were within the normal range, effectively ruling out pancreatic inflammation. We continued to eliminate possibilities. Each potential organic cause we investigated rose as a possibility, only to fall away as diagnostic tests yielded normal results. We were left with a puzzle. We also reviewed her current medications. She was taking sertraline, an SSRI, which can sometimes contribute to dyspeptic symptoms. This was a key consideration. Under careful supervision, we attempted a gradual tapering of her sertraline dosage, but this intervention yielded no change in her persistent symptoms. The medication wasn't the cause. This thoughtful pause led us to a critical question. If it's not acid, not an infection, not gallbladder issues, and not pancreatic disease, what could be the underlying cause? Before pursuing more exotic diagnoses, it is always prudent to revisit the basics and ensure no alarm features were overlooked. A careful review is always warranted. We confirmed her weight remained stable, there was no evidence of anemia, and no occult blood was detected in her stool. The basics were still in order. Her family history remained negative for gastrointestinal cancers or other significant hereditary conditions. This provided further reassurance. Every piece of evidence continued to point towards persistent symptoms without any clear indicators of danger or organic pathology. We were dealing with a functional issue. At this juncture, despite the absence of alarm features, it became imperative to perform an upper endoscopy. We needed to look directly at the source. This procedure would allow us to confirm our suspicions of a functional disorder and, crucially, to definitively rule out any subtle organic pathology we might fear. It was a crucial step. During the endoscopy, the scope glided smoothly, revealing a normal esophagus, a smooth stomach lining, and healthy gastric folds. The anatomy appeared perfect. There were no visible ulcers, erosions, or other structural abnormalities that could explain her persistent symptoms. The visual inspection was reassuring. Biopsies taken during the procedure further confirmed the absence of H. pylori infection, atrophic gastritis, and celiac disease. The microscopic findings were also normal. Anatomically, everything appeared perfect, yet the perplexing question remained. Why does she still feel so persistently full? The mystery continued. The answer to her persistent symptoms lay not in structural abnormalities, but rather in heightened visceral sensitivity. The problem was in how her body perceived things. This led us to the diagnosis of functional dyspepsia, a disorder where the gut and brain misinterpret normal sensations. It's a complex interplay. This miscommunication creates real and tangible discomfort for the patient, even in the absence of any visible disease or structural damage. The symptoms are very real. It's crucial to understand that this condition is not in her head. It's a genuine issue rooted in the complex wiring of her gut-brain axis. It's a physiological problem. Treatment for functional dyspepsia involves a multifaceted approach tailored to address the patient's specific symptoms and sensitivities. A personalized plan is key. Our patient began a regimen of low-dose amitriptyline, along with dietary modifications including smaller, more frequent meals and a low-fat diet. We addressed multiple factors. Stress reduction techniques were also incorporated into her treatment plan, recognizing the significant impact of stress on gut-brain interactions. We addressed the whole person. Within 6 weeks of initiating this comprehensive treatment, the heaviness she experienced began to noticeably ease. The treatment was showing results. Remarkably, within 3 months, she reported eating normally again, with a significant improvement in her overall quality of life. The patient was doing well. Let's review the essential roadmap for managing dyspepsia, ensuring a systematic and effective diagnostic and treatment pathway. A clear approach is vital. First, if alarm features are present or the patient is 60 years or older, an endoscopy is the immediate next step. This is the initial triage. If no alarm features are identified, the second step is to test for Helicobacter pylori infection. This is a common cause to rule out. Third, if the H. pylori test is negative, a trial of proton pump inhibitors, or PPIs, should be initiated. This is a standard treatment. Fourth, if symptoms persist despite the PPI trial, an endoscopy with biopsies is then warranted. Further investigation is needed. Finally, if the endoscopy results are normal, the diagnosis of functional dyspepsia can be made, and treatment should target the specific symptom phenotype. This is the final step. This case underscores that dyspepsia is far more complex than simply an issue of acid production. It's a multifaceted condition. It's about understanding when to meticulously investigate for organic causes and, equally important, when to recognize the absence of structural disease. Careful assessment is key. Sometimes, the most challenging diagnosis involves realizing that the stomach itself is perfectly healthy. The absence of disease can be the answer. In such instances, the true healing lies in addressing the intricate dialogue between the gut and the brain. It's about treating the whole patient. Thank you for joining us in exploring this fascinating case of persistent epigastric fullness. We hope this has been informative.